achievers in Singapore. Dr. Kong also received the prestigious National Day Award from the President of Singapore for his contribution to scientific research and research administration in Singapore. Without further ado, I will now hand over to our chairperson of this evening's webinar, Dr. Kong Wei Lo.
Thank you, Jen, for the very generous introduction. Good evening, ladies and gentlemen. A very warm welcome to this evening's GI Oncology webinar, kindly sponsored by Bayer Singapore. I sincerely hope our friends in Malaysia, Hong Kong, Thailand, Vietnam are staying safe and coping well in this COVID-19 pandemic. I hear that there are nearly 400 attendees who have registered for this evening's webinar. It is my distinct privilege to be the chairperson of this evening's proceedings. Tonight, we will hear 3 interesting and informative presentations on the use of Regorafenib in various GI cancers. As you know, Regorafenib was first approved as a third-line treatment for metastatic colorectal cancer in 2012. It then received FDA approval in 2013 as a third-line treatment for advanced gastrointestinal stromal tumor, or GIST. And more recently, in 2017, Regorafenib was approved as a second-line treatment for advanced hepatocellular carcinoma following first-line usage of sorafenib. In these past 8 years, we have learned how to optimize the dosage of the drug and how to manage treatment-related toxicities. You can say we have become very comfortable with the drug. In the horizon are some exciting developments relating to Regorafenib, either as monotherapy or in combination with other agents such as immunotherapy. Tonight, we have an exciting lineup featuring 3 outstanding speakers from US, Germany, Singapore, and Hong Kong. It is now my distinct privilege to introduce my esteemed colleagues. Dr. Axel Grothy is our first speaker tonight. He's the Professor of Oncology and Director of GI Cancer Research at the West Cancer Center, University of Tennessee in Memphis, Tennessee, USA. Dr. Grothy received his medical degree in Germany. After his research fellowship at the MD Anderson Cancer Center, he joined Mayo Clinic as a consultant in 2005 and was quickly promoted to the Professor of Oncology in 2007. He eventually left Mayo Clinic in the summer of 2018 to join the West Cancer Center. Dr. Grothy is a giant in the field of GI oncology. Besides his famous IDEA study of adjuvant chemotherapy for colorectal cancer, he has led numerous other GI cancer studies. And relevant to the webinar tonight, Dr. Grothy's name is associated with most of the major Regorafenib studies. He's a member of the NCCN Guidelines Committee for Colon, Rectal, and Anal Cancer, and also a member of the ESMO Guidelines Committee for Colorectal Cancer. Dr. Grothy was a 5-time recipient of the Teacher of the Year recognition at the Mayo Clinic, and he has co-authored more than 500 articles, books, book chapters, editorials, abstracts, and letters. We just heard that Dr. Grothy has encountered some train transport issue in Germany where he's at, and he's unable to join us in the initial presentation. Now, fortunately, Dr. Grothy had already pre-recorded his full lecture a few days ago, and we shall be able to enjoy the lecture just the same. He will try to join us at the Q&A segment, and if he can get a reliable connection. Otherwise, the rest of the panel specialists are more than happy and able to answer all the questions that you'll be posting later on. Next, we have Dr. Yong Wei Ping, who is a senior consultant at the Department of Hematology Oncology at the NUS National University Cancer Institute, Singapore. He's also an adjunct research fellow at the Cancer Science Institute of Singapore at NUS. Dr. Yong obtained his medical degree and postgraduate training in the University of Aberdeen, Scotland. He was awarded the A-Star International Clinical Pharmacology Fellowship at the University of Chicago. And upon his return to Singapore, he was awarded a 3-year investigatorship award under the Clinician Scientist Award to further his research into personalized therapy. Dr. Yong leads the therapeutic arm of the Singapore Gastric Cancer Consortium. He is also the chairman of the National Healthcare Group Domain-Specific Ethics Review Board. His clinical interest is in GI cancers, and his research interests are pharmacogenetics and epigenetics in cancer. And some of you may also know that Dr. Yong is an accomplished photographer and a scuba diver. Tonight, Dr. Yong will be giving us a glimpse of the exciting future applications of Regorafenib in adult solid tumors, as well as other targeted therapies in GI oncology. Last but certainly not least, we have Dr. Lam Ka-on from Hong Kong. Dr. Lam is currently a clinical assistant professor in the Department of Clinical Oncology at the University of Hong Kong. He graduated with distinction in MBBS from Hong Kong U in 2005, and after excelling in his postgraduate training, Dr. Lam joined Hong Kong U as a clinical assistant professor and obtained his specialist qualification in clinical oncology in 2013. He was selected as the Distinguished Young Fellow of Hong Kong Academy of Medicine in 2014. Dr. Lam's research interests are novel therapy strategy and circulating tumor cells in GI cancers and nasopharyngeal cancer. And following his stint on drug development at the Royal Marsden, UK, he has participated as a PI or site PI in 19 clinical trials in GI oncology. He's also the founding member of the Hong Kong SBRT study group. He's truly a rising star of Hong Kong oncology. Dr. Lam will share with us two interesting cases of GI cancers treated with Regorafenib, illustrating the real-world usage of this important drug. This is the agenda for this evening's symposium. Dr. Grothy will deliver his keynote address in a pre-recorded video, followed by Dr. Lam, who will share two interesting cases on the use of Regorafenib in the real-world setting. And finally, Dr. Yong will help us to gaze into the crystal ball on the future applications of Regorafenib. And all the questions will be taken at the end of the Q&A session. And I urge everyone to send in your questions, big or small, so that our experts can share the insights during the panel discussion. Now, just some housekeeping rules. You're encouraged to send in your questions as the meeting proceeds. Don't wait for the end of the session. As the question comes to your mind, do send in. Please type your questions in the Q&A portal, which you can find at the bottom of your screen. All the questions will be answered at the end during the panel discussion, and we'll try to raise all your questions if time permits. In the event that your question is unanswered by the time the session ends, we will respond by email after the meeting for non-anonymous questions. And all attendees will be muted and the videos turned off during the meeting proceeding. So without further ado, we shall now go ahead and listen to the exciting presentation by Dr. Axel Grothy on Regorafenib, how to optimize its usage.
Thank you very much for having me. The fact that you're watching this here right now means that I wouldn't be able to call in live, and of course I would have liked to be there in person and not have these virtual meetings. I mean, we're all Zoom experts now, so that is a Zoom recording here to talk about the optimized use of Regorafenib in GI cancers. Hopefully it ties nicely into the whole agenda that we see today. So this is my disclaimer. This is my opinion. I put slides together myself. This is not an on-label talk. So let's talk about colorectal cancer first before we, in the second part, go to hepatocellular carcinoma. Right now, as medical oncologists, we face the challenge to how do we optimize treatment for a patient with metastatic disease in a palliative setting? We have a lot of different treatment options. And, I need to expand this puzzle here because now we have Regorafenib for BRAF V600E mutant tumors available. And the question is really, how do we make all these drugs and all these combination therapies available to as many patients as possible, including PD-1 antibodies. The goal of medical therapy in metastatic colorectal cancer is to find the right treatment for the right patient at the right time. It's clearly that this one-size-fits-all approach does not fit anymore. And individualized therapy in colorectal cancer did not start with KRAS in 2008. We've made individualized, personalized treatment approaches for patients for quite some time, depending on goal of therapy, patient characteristics, etc. But one key principle, I think, stayed the same compared to what we started on, when we had 3 drugs that worked in colorectal cancer, 5-FU, oxaliplatin, and irinotecan. We showed that patients having access to all three agents in whatever sequence really optimize outcome. And I think this is still true nowadays when we have biologics and small molecules. The more options patients have, the better it is, and the longer we can keep them alive. Now, I want to highlight a couple of points that elucidate the importance of not just first-line treatment, but later-line therapies. First of all, when you look at the first, second, and third-line phase 3 clinical trial data, in the middle part, you see the hazard ratios. On the right, you see the median overall survival improvement in months. It's very clear that there's never been this one breakthrough moment in colorectal cancer, at least not for the majority of patients. MSI tumor, MSI-high tumors, immunotherapy, that's a different story. But the vast majority of patients really benefit from the incremental additions of survival benefits over time, not just with first-line therapy. Regorafenib and TAS-102 have a place in a later-line setting, in a third-line setting, in guidelines, whether it's NCCN or ESMO. They all place them kind of head-to-head after failure of irinotecan or oxaliplatin-based therapy with or without biologics. So let me talk a little bit about the background data that we have that support the use of regorafenib and TAS-102 in patients with metastatic colorectal cancer. We have very well conducted phase 3 studies comparing regorafenib to placebo in a Western patient population, the CORRECT study, and in an Asian patient population in the CONCUR study, where we had less heavily pretreated patients. And there is a clear survival benefit for the use of regorafenib in a later line setting, 23% reduction in the risk of death in the CORRECT study, 45% in CONCUR, with hazard ratio of 0.77 and 0.55. I think this is clinically meaningful. And then we have the same kind of a lot of data in observational cohort studies, so-called real-world studies, where we have thousands of patients now treated in various countries, in various healthcare settings. And overall, we've seen that over time, we actually see more and longer survival in the observational cohort studies and in the most recent phase 3 study, IMBLAZE 370, where regorafenib actually was used as a control arm against the use of atezolizumab and cobimetinib, 8.5 months in randomized trial. The REDOS study, which I'll come back to later, has 9.8 months median survival in the escalation arm. We also learned that, there are long-term responders. When we talk about long-term responders when they have a PFS for more than 4 months, those patients actually have a very good survival. So it's kind of a time-based event. And, translating this into a narrative for patients, I tell patients, when we do a scan after 2 months of therapy, and you have about a 45 to 50% chance of not having progression of disease. And if that happens, you have a 50% chance to be alive after a year. That is clinically meaningful for patients. So the problem with regorafenib, of course, is the adverse events that come early and can be subjectively challenging for patients, particularly hand-foot skin reaction, this inflammatory reaction in hands and feet, some blister formation sometimes, fatigue, voice changes. Patients feel regorafenib, particularly if you start with the higher dose of 160 milligrams. One thing we've learned from the analysis of CORRECT and other studies is that the side effects come early. They come within the first cycle, first 2 weeks actually, and we need to monitor the patients more closely. When these side effects occur and we see patients back after 2 weeks, they can be the highest grade they'll ever have because subsequently we'll modify treatment, we'll modify doses, we treat the side effects. And we've learned that when we continue treatment over time, patients will still they actually have a lower prevalence and lower severity of these side effects that they initially started with. So the idea is patients more or less get used to this drug, and it's our goal to guide them through the first cycle, the first 3-4 weeks of therapy. And this is where the idea of let's escalate the dose and do a randomized study compared to standard dosing with 160 milligrams came about, the so-called REDOS study, which was published about a year and a half ago by my friend Tony Saab. We compared an escalating dosing strategy starting with half the daily dose, meaning just 80 milligrams per day first week, then 120 milligrams per day in the second week, and then hopefully 160 milligrams in the third week, followed by 1 week rest, compared to the standard dose of starting with 160 milligrams. Now, the primary endpoint of the study tried to capture the efficacy and the toxicity of the regimen, because we wanted to make sure that starting with a lower dose did not harm patients in terms of reduced efficacy. So the primary endpoint was the proportion of patients that wanted to start and could start cycle 3 after the first scan, because they would only start cycle 3 if they tolerated the drug. And number 2, actually had at least stable disease on the scan. And the study was positive for the escalating dosing strategy. 43% of patients were able to continue the treatment into cycle 3 compared to when they had the escalating dosing strategy compared to the standard dose, just 24%. And this is kind of a very kind of detailed analysis. Every single patient is aligned here, and you see the different doses they were on per week. And you can see there's a lot of flexibility in our dosing strategy, and this is really something which we need to keep in mind. We want to increase the duration of therapy of regorafenib because it's a cytostatic agent, and cytostatic agents only work as long as you give them. So when you stop the treatment, it is patients' tumor will progress. So optimizing duration of therapy is important. And here you can see you use flexible dosing strategies to keep patients on therapy. Very importantly, the difference between escalating and de-escalating dosing strategies the first 2-3 weeks. And we did a quality of life analysis at week 2. And in every single item that we use, the standard dosing strategy, the old standard dose, 160 milligram per day starting dose, showed a decrease in quality of life, whether it's overall quality of life, walking ability, fatigue, etc. Whereas when we use an escalating dosing strategy, starting with a lower dose and going up, quality of life was maintained. And this is an important point I think we've learned now. NCCN guidelines have rapidly adopted this new dosing strategy. They were really ready to integrate that as soon as Tony Saab presented the data at ASCO GI in 2018. The NCCN guidelines included the escalating dosing strategy as an option. So we've learned a lot about regorafenib. We have better patient selection criteria. We should not use it in patients with PS2. Probably better to use it in less heavily pre-treated patients. We need to educate patients about the kinetics of side effects and what they can do, for instance, to mitigate side effects like removing calluses in their feet before treatment initiation. Fatigue is a big issue, of course, and we need to tell patients to be patient with themselves. And we need to monitor patients, particularly in the first 1 or 2 treatment cycles. Nowadays, we have telemedicine approaches in the time of COVID. And I normally call in with my patients about a week into their treatment to see how they're doing. Now, one of the advantages right now in the COVID era, but also in general, is regorafenib, and this gives patients a break from chemotherapy because it's not cytotoxic chemotherapy. It gives them a break from these sometimes years of chemotherapy that happened before. Bone marrow can regenerate, and with longer duration away from cytotoxic therapy, we believe actually that subsequent lines of chemotherapy-based regimens might actually have a better chance to work. And one of those drugs that we can use afterwards is TAS-102. It's a cytotoxic agent. It's a fluorothymidine, so fluoropyrimidine. It was developed very similar to regorafenib in 2 large randomized trials, one worldwide, one Asia-focused, 2-to-1 randomization against placebo. The data are positive. The pivotal RECORE study showed there's an improvement in death rate, 32% reduction of death events on the study, hazard ratio of 0.68. You see the progression-free survival curve, which is very similar to regorafenib. I'll show you that in a minute. Similar to regorafenib, about 45 to 50% of patients will not have progression of disease at the first scan after about 2 months, but a substantial number of patients just progresses right up front. Now, the toxicity of TAS-102 is very different than regorafenib. It is mainly neutropenia, which for most patients, fortunately, is asymptomatic, at least in the time of COVID. There might be some concerns right now in terms of neutropenia, whether this is the side effect you would like to have. But limited non-hematologic toxicities, patients normally subjectively tolerate this drug better. And I do actually believe that the pool of patients that is candidate for TAS-102 is larger than the pool of patients for regorafenib. Now, there are a couple of interesting things here, the coronavirus pandemic reference, that patients actually develop neutropenia. They have a better chance to benefit from this drug, likely from pharmacokinetic reasons. The plasma levels are higher and the anti-tumor efficacy is higher. This is similar to actually what we saw with regorafenib, coming back to that, with hand-foot skin reaction. Patients who develop hand-foot skin reaction have better outcome on regorafenib. Now, there are a couple of things which are interesting. First of all, we do have data for TAS-102 after regorafenib, and the data are very similar to patients who are not pre-treated with regorafenib. So we do know that prior treatment with regorafenib doesn't take anything away from TAS-102. In fact, when you look at the prior lines of therapy, it seems to be that the more heavily pre-treated patients are, the better TAS-102 works, which is very different than what we know about regorafenib. Here, I promise you the comparison progression-free survival curve. This is TAS-102. This is regorafenib. Going back, TAS-102, regorafenib, very similar activity. And when you put all the phase 3 trials on one slide here, there's a trend toward what I said before. Regorafenib seems to work better in less heavily pre-treated patients, like in the Concur study. TAS-102 seems to work better in a more heavily pre-treated patient population. The Terra study was conducted in Asia, and hazard ratio is 0.79. It's the weakest hazard ratio of these trials here in cross-trial comparison for overall survival. So why would I use regorafenib before TAS-102? That's my standard approach because I want to use all active agents in all patients as much as possible, meaning Rego and TAS. And first of all, I mentioned Rego has better benefit in less heavily pre-treated patients. We should not have patients' performance status deteriorate to PS2, which could happen when they had too many lines of therapy. But so when patients are on regorafenib and develop PS2, I think they're still candidates for TAS-102 in a lot of cases. Side effects of regorafenib can be managed. You saw redos, low quality of life detriment. Cytotoxic therapy like TAS-102 can be active after rego. And actually, we have data on that from the phase 3 study. Now, there's an interesting combination that has emerged, which is TAS-102 plus bevacizumab, and we have data in a later line setting with TAS plus bev from a Per Pfeiffer study, randomized trial in Denmark. Interesting improvement in progression-free survival and overall survival. And in my patients, I actually try to use this as my preference when I use TAS-102 after regorafenib. I add bevacizumab. It also lends itself towards this idea of continued VEGF inhibition across different lines, which we know works. In the first-line setting, Eric van Kutzen just recently published data on TAS-bev versus capecitabine bevacizumab. There's a numeric difference, at least in favor of TAS plus bev, with less hand-foot syndrome, which is, of course, the complication of bevacizumab. So it's a realistic combination, and it's as expected because the fluoropyrimidine is nicely combinable with bevacizumab. Now let's move on to HCC, which is a clear unmet need worldwide. By 2030, we'll have 1 million deaths per year, and what the underlying mechanism is, for the generation of HCC is different between different countries. In the United States, it's mainly NASH or alcohol-induced liver cirrhosis or hepatitis C. And in China, it's mainly hepatitis B. So there are different kind of pathogenesis features between different countries here. But it is clearly a cancer of an unmet need, high prevalence, and in later stages, very detrimental, very kind of rapidly progressing in some cases. Particularly, the Barcelona liver cancer classification here looks at the patient with advanced stage C as the ones who are candidates for systemic therapy. I think the more we have active systemic therapies, the more we might actually move this treatment into the intermediate stage, stage B, but that's something that is a matter of clinical investigation. Until early 2020, we actually already had several treatment options FDA approved in the management of unresectable HCC, starting with sorafenib and lenvatinib, based on a study that I'll show you, the REFLECT study, showing that there is non-inferiority for lenvatinib. And then second-line options, regorafenib, cabozantinib, ramucirumab for certain patients with high AFP. Then even immunotherapies with nivolumab and pembrolizumab, which were approved based on single-arm studies, mainly based on response rate and duration of response. And the cabozantinib study also had kind of a mix between second and third-line patients. So that is the a lot of agents, actually. What a change compared to the initial data that we saw in 2008 when Regorafenib really changed this landscape as the first drug that showed improvement in survival in the SHARP study, in the Asia-Pacific study, with hazard ratios of 0.69 for overall survival and 0.68, setting a standard of care, which stayed standard of care for a long time. The REFLECT study compared lenvatinib to Regorafenib as a first-line treatment. Lenvatinib, a very strong VEGF inhibitor. Main toxicity profile here is rapid hypertension, but probably less skin reaction than Regorafenib. No difference in overall survival. There was a difference in response rate and progression-free survival, a secondary endpoint in favor of lenvatinib, but the readout for overall survival was no difference, but clearly non-inferior, FDA approved. The RESTORE study actually had a very interesting design. Patients who had tolerated Regorafenib first line at a certain dose for a certain time were randomized 2-to-1 in a second line setting. This is one of the first positive second line trials, randomized trials, to Regorafenib, gold standard dose, 160 milligrams starting dose, or placebo. A large study, more than 500 patients were included around the world. The study was clearly positive with a hazard ratio of 0.61, long median survival for Regorafenib, 10.7 months. And when you look at the sequence, you started with Regorafenib, followed by Regorafenib. Actually, patients lived 26 months when they went from Regorafenib to Regorafenib. Of course, there's a selection process in there because, patients who are candidate for a second-line trial are special patients. But if you really are able to go through this sequence, patients can live more than 2 years. Adverse events with Regorafenib in HCC are very similar to what we saw with colorectal cancer, perhaps a little bit more mitigated because patients already have had experience with Regorafenib in the study, so they had already experienced the side effects of a multi-kinase inhibitor. Again, similar to what I mentioned to you in colorectal cancer, hand-foot skin reaction was associated with better outcome for patients. Here, the hazard ratio actually of 0.52, very strong. It doesn't mean that patients who don't develop hand-foot skin reaction have no benefit from Regorafenib, because you don't know how these patients would do with placebo. So be careful, don't stop Regorafenib. Patients don't develop hand-foot skin reaction. Now then there are initially, let's say, surprisingly negative studies, at least statistically negative studies, randomized studies for pembrolizumab and nivolumab. Pembrolizumab in second line versus best supportive care, not even an active comparator like Regorafenib or cabozantinib. With the statistical design that was posted here, no superiority. The p-values here are not, the cutoff here for a positive p-value would not be 0.05. It's more stringent because it's an alpha split actually here, because they looked at overall survival and progression-free survival separately, and these were co-primary endpoints. So this is at least informally a negative study. And similarly, probably also surprising, nivolumab versus Regorafenib first line trial that was really awaited, checkmate 459, no difference in survival, even though there might be a trend, let's say, at the tail of the curve to have better outcome for nivolumab, but clearly not anything that would be too intriguing to think that nivolumab is standard of care. But then came IMbrave 150 at ESMO Asia 2019, a randomized study, atezolizumab, bevacizumab versus Regorafenib as first line, 2-to-1 randomization, large study, more than 500 patients. Importantly, all these patients had to have a scope to see whether or not they had varices, which could predispose them to bleeding because of bevacizumab. And overall survival as endpoint was clearly reached, highly statistically significant, clinically meaningful, 6 months overall survival rate, very different, and the time of the publication, median overall survival not even reached, and the duration of response, again, not reached yet for the atezolizumab, bevacizumab combination, higher response rate for about 25 to 30%, clearly higher than Regorafenib. Better safety profile than Regorafenib, but we know that atezolizumab and bevacizumab are not that toxic. So in conjunction with the quality of life analysis, patient-reported outcomes, that atezolizumab delayed the time to deterioration of patient-reported quality of life compared to Regorafenib. I mean, this really set a new standard of care. And actually, since the presentation, I've been using it in my clinical practice. So where does it fit in now? So the atezo-bev combination is kind of one step ahead of the kinase inhibitors, that we've otherwise seen approved now. So it's kind of a minus first-line therapy. And then the question is, should we use, what's our second line after atezo-bev? Is it going back to Regorafenib, Lenvatinib, and then go through the sequence of events, or should we skip over to Regorafenib, Cabozantinib, etc.? This is all still kind of a matter of clinical studies. I think the other very interesting emerging options, Lenvatinib, pembrolizumab has some very interesting data in first-line setting in more than 100 patients. It didn't make it to FDA approval or accelerated approval, but clearly interesting along the lines of a multi-kinase inhibitor plus anti-PD-1 plus potentially anti-CTLA-4 antibody, although this might be a little too toxic. It could very well be that atezolizumab is just a temporary interim new standard of care. We will see what happens. There's a lot of research going on. Here, the ongoing phase 3 clinical trials, including Himalaya and LEAP-002. So that is actually something which we can be really excited about. Now, in conclusion, I think I've shown you that Regorafenib has clear efficacy in metastatic colorectal cancer and unresectable HCC. Evidence was generated in very carefully conducted randomized phase 3 studies and observational cohort studies, the so-called real-world evidence. The escalating dosing strategies in readouts have made Regorafenib much better tolerated, giving it kind of a second chance. And, this is the standard of care. I think how Regorafenib should be used as a clear role in the third-line setting. Should not be used it should actually be used in less heavily pre-treated patients. So I would caution everyone to recycling prior cytotoxic chemotherapy too much and allow patients' performance status to deteriorate before Regorafenib is used. That's not the way to use this drug in the best way. And the treatment options for HCC have dramatically expanded in the last years, which is clearly very welcome. Right now, with atezo-bev as first line, and no one has a good idea what's the best sequence of events afterwards. We have a lot of treatment options. It will take some time to figure all this out. Thank you very much for your attention.
Okay, before we proceed further, I just want to remind attendees that you should key in your questions as soon as they come to your mind, so that you won't forget the questions later on. And we'll take all the questions at the Q&A later. So Dr. Axel Grothy just gave us a very comprehensive review of GI oncology in 25 minutes, which is quite difficult to do. Particularly, he emphasized the fact that in metastatic colorectal cancer, it's important to make sure that the patient will get exposed to all the effective agents, including the third-line space, which is Regorafenib and TAS-102. He also postulated some theory as to why Regorafenib might be better used before TAS-102. So these are the theories and data that we've just heard. It will be very important to make sure that we understand how to use a drug in actual daily clinical practice. So for this, we are very fortunate to have Dr. Lam from Hong Kong sharing with us two very interesting cases where Regorafenib play a role in prolonging the survival of the patients. And I'll let Dr. Lam take over the stage. Dr. Lam, please.
Thank you, Chairman. Thank you for the introduction, and thanks, Bayer, for having me in this webinar. I'm now sharing my screen. I believe all of you can see my screen now. Yeah. So I'm K.O. Lam from the Department of Clinical Oncology. I'm a specialist in clinical oncology in the University of Hong Kong and Queen Mary Hospital. Here is my disclaimer. And in the next 20 minutes, I'm trying to link up the content of Axel's and Wei-Bing's talk to daily clinical practice by the use of very illustrated cases of mine to highlight two principles. One is the optimizing the use of regorafenib monotherapy with flexible dosing. And the second is to highlight the promising result of novel combination with regorafenib. So case 1, CKM is a 74-year-old male. He's a retired salesman, non-smoker and non-drinker. He had ischemic heart disease with percutaneous coronary intervention in 2015. He has no family history of colorectal cancer. And in a nutshell, he has metastatic rectal cancer with multiple lung metastases, KRAS mutant, BRAF wild type, and proficient in MMR. A very typical molecular profile. So the story actually started in 2016. He presented with CA rectum with synchronous multiple lung metastasis. And in fact, at that time, we are not quite sure about the nature of multiple lung nodules, which are very small, with only one of them reaching the size of 1.1 centimeter, but it's too deep for histological confirmation. However, the primary was very symptomatic with pain, tenesmus, and bleeding. So for the benefit of doubt, we treat him with the long-course chemoradiotherapy to primary rectal tumor, followed by laparoscopic low anterior resection, and at the same time monitoring the progress of the uncertain nature of the lung nodules. The primary tumor turned out to be moderately differentiated adenocarcinoma, YPTV N0, with clear resection margin. And in November 2016 till February 2017, he was given 6 cycles of capecitabine and drug holiday because he's a rather old age and the lung nodules are of uncertain nature and is totally asymptomatic in the chest in the respiratory aspect. However, there's known PD of lung metastasis in March 2017, but the patient preferred to delay chemotherapy because at that time he was still asymptomatic. So in July 2017, there is further progressive disease, and we started bevacizumab with Celox, followed by maintenance bevacizumab and capecitabine. And you can see that there are multiple lung nodules that have grown significantly in 1 year. And then in September 2017 and March 2018, the CT showed stable disease with the typical cavitating response of bevacizumab. In 2018 November, there are further progressive disease, but the disease is still confined to the lung only. However, there are more than 20 of them. In November 2018, we started bevacizumab and Cimiri, followed by maintenance bevacizumab and capecitabine. I guess in this patient, we apply all the principles of treatment for metastatic colorectal cancer, maximizing the outcomes of patients with maximum exposure to oxalipatin, irinotecan, and fluoropyrimidine, and apply the principles of bevacizumab anti-angiogenic beyond progression. And at the right time, we'll step down the treatment to maintenance bevacizumab and capecitabine. In March 2019, CT showed stable disease with cavitating lung metastasis. And in October 2019, however, the CT showed further progressive disease with increase in size and number of lung metastases. Unfortunately, the patient also started to have more chest symptoms with shortness of breath. There are multiple lung nodules, and some of them with this cavitating response typical of anti-angiogenic agent. So what can you expect from this 76-year-old patient now? He said, "Doctor, I'm tired of IV therapy, but I'm still keen to continue treatment." So at that time, we discussed the options of regorafenib and TAS-102 with him. But in reality, at that time, TAS-102 is still far more expensive than TAS-102. And the patient prefer to start with Regorafenib and reserve the TAS-102 later. So we started Regorafenib 80 milligram per day according to the REDUCE study. And in February 2020 and in April 2020, just 2 months ago, we observed stable disease with cavitating lung metastasis. So actually, the stable disease, the progression-free survival is already 6 months, and the days is still counting. So it's now approaching 8 months now. What we can observe is the very typical cavitating response with Regorafenib. You see in October 2019 at the baseline, and then after treatment with Regorafenib in April 2020, there are nice cavitatory response of the lesions in most, if not all, the lesions. And we learned from the radio-correct study, it says that cavitating lesion is associated with better control of the disease and improved clinical outcomes in terms of survival. And more importantly, there's also improvement in the symptoms. There's less relief of the shortness of breath. However, side effects with Regorafenib, even at the dose of 80 milligram per day, is still challenging. There were grade 2 malaise and hypertension, and we need to add in antihypertensive treatment. And there was also grade 1 gum bleeding, because the patient is also on aspirin for ischemic heart disease. But the most problematic is grade 2 hand-foot skin reaction, which fortunately subsided quickly with treatment interruption. I guess for most of you with the experience of using Regorafenib and with the painful experience of hand-foot skin reaction, you know that not many treatment help, but interruption of the treatment actually can lead to a very quick resolution of this side effect. So initially, even at the 80 milligram per day, he can only tolerate 4 days on and 3 days off. Usually, for patients starting with Regorafenib, I will brief them with the timing of onset of this kind of painful hand-foot skin reaction. Of course, initially, I will suggest the patient to be compliant to the standard dosing to continue the treatment for 3 weeks on and 1 week off. But with more and more experience, I know that flexible dosing and individualized treatment is important to maximize the duration of patient on treatment. So I usually ask the patient to observe for painful hand-foot skin reaction. You can continue the Regorafenib until you have this pain, or until you started to have more pain in the hand and foot. Then you can stop for a while. And once the hand-foot skin reaction subsided, at least the pain subsided, irrespective of whether or not there is still desquamation, they can resume the treatment again. So from time to time, this strategy is very useful with shared patient education. They can time their own, they can regulate their own Regorafenib schedule, minimizing toxicity and potentially maximizing efficacy. Currently, the patient is on 8 days on and 6 days off regimen. And as we have talked about, it's already 8 months of progression-free survival, and the days is still counting. Now the patient is 78 years old and still having a relatively normal daily activity and good quality of life. So when we talk about hand-foot skin reaction as a nasty toxicity, we know that it is associated with better clinical outcome. According to a post-marketing study in Japan, survival is related to the onset of hand-foot skin reaction within the 4 weeks after treatment start. And in fact, the median overall survival was longer in patients with hand-foot skin reaction within the first 4 weeks after treatment starts. And for those patients with hand-foot skin reaction within the first 4 weeks, the survival is 7.7 months. For those without hand-foot skin reaction, survival is around 5.9 months. So it's important to manage adverse events, especially dermatological events, for better clinical outcomes. So now we talk about the dose optimization of regorafenib. We try to start with regorafenib and 160 milligram per day, 3 weeks on and 1 day off, one week off as a standard schedule initially. But you know that in the initial phase 1 dose finding study, regorafenib 116 milligram is actually the maximum tolerated dose. So which implies that a significant number of patients can have grade 3/4 toxicity with this dosage. So the question we have to ask, how low the dose is still sufficient for efficacy? And if you look at the phase 1 dose finding study, you can see that there's a dose-dependent increase in systemic exposure of the parent regorafenib drug up to 60 milligram, from 10, 30 to 60. However, further increase in the dose do not result in a significant increase in systemic exposure. So we can start with 120, we can start with 80, but certainly starting dose lower than 60 milligrams should be avoided to respect the pharmacokinetics of regorafenib. And here also comes the concept of first cycle dosing optimization of regorafenib. As we have learned from Axel's talk, that most of the toxicity comes in the first few cycles or even the first few weeks of regorafenib treatment. And 20% of patients require more than 1 dose reduction, and 70% of patients require more than 1 dose of interruption. The $1 million question is how to improve the tolerability of regorafenib. So we have 2 landmark studies. One is the REDUCE study, and one is the REARRANGE study, to look at the alternative dosing strategy in regorafenib. They share the similar control arm of standard dose and second cycle of standard dose, but they differ in the dose at the first cycle. For the REDUCE study, as mentioned by Axel, they have weekly escalation of the dosing if there is absence of significant toxicity. However, on the REARRANGE study, they either use lower dose, flat dose of 120 milligram daily in the first cycle, or intermittent dosing, 1 week on and 1 week off, which is similar to the dosing schedule used in the patient that I shared with you. In the REDUCE study, as mentioned by Axel, cycle 1 dose escalation approach permitted significantly more patients to start cycle B compared to standard dosing. And in fact, there is a trend favoring improved overall survival and progression-free survival in the escalating dose arm. And in the REARRANGE trial, which is a primarily European study, the 3 dosing schedule do not differ significantly in terms of the grade 3/4 adverse event, which is actually the primary endpoint of the study was not met. However, if you look at this in other perspective, by using flexible dosing, in fact, it did not jeopardize the efficacy of the treatment. So that in turn support more flexible dosing. Although we try to start with lower dose, but we also aim to escalate the dose to the standard dosage. And in fact, if you look at the correlated study, one of the largest observational cohort study for regorafenib in MCRC. 30% of patients started regorafenib at 120, and 12% of them can be escalated to higher dose. And for those started at even lower dose of 80 milligrams, roughly about half of the patients can be escalated to higher dose. This is my own experience. We published it 4 years ago, and there were 45 patients. And we find that for those starting with lower dose of regorafenib, there is a trend towards more favorable survival, and most importantly, there was significantly lower dose of hand-foot skin reaction. And for those who start at lower dose of regorafenib, 60% of them can in fact escalate to higher dose, and they show more favorable survival outcomes. So the lesson we learned with the case 1 is we should have flexible dosing, and that flexible dosing can be very individualized, and you learn with experience. The case 2 we have is a 56-year-old male businessman, chronic smoker, chronic drinker, non-smoker, with low family history of colorectal cancer. He has recurrent metastatic rectal cancer with liver, lung, and lymph metastasis, RAS and BRAF wild type, HER2 negative, and proficient in MMR. So in October 2015, he had surgery for the rectal cancer, which turned out to be stage 3, but the patient refused any neoadjuvant or adjuvant therapy. And then subsequently, he developed liver metastasis in just a few months' time. And he was given 2 cycles of Celox and multiple courses of RFA and local therapy, followed by FOLFIRI and CIK therapy. These are all the treatment given in mainland China, where CIK therapy is a kind of cytokine therapy, is very popular, but not totally evidence-based. And the patient also subsequently have a progression of disease and was given more cycles of C225 and FOLFIRI. Then the patient come to me in early 2018 saying that, doctor, you know, a lot of patients come from mainland China and to Hong Kong for further treatment, and saying that, doctor, I want the best treatment. But that is a very difficult question to answer. For colorectal cancer, heavily pretreated like him, we give him palliative radiotherapy to the pelvis for symptom control, and we also try to obtain a new liver biopsy to look at the molecular profile of the tumor. It was marginally high tumor mutation burden, but still MSS, and some other mutation and molecular alterations suggest sensitivity to mTOR inhibitor. However, he needs palliative bypass surgery in March due to a significant obstruction. And from May 2018 to September 2018, we treated with TAS-102 with mixed response. So we added in panitumumab. Because of the mixed response, some of the lesions respond quite well, but some of the lesions progress. So we added in the panitumumab in September 2018. According to the Apollo study by Japanese colleagues, showing that panitumumab combining with TAS-102 may have response rate up to 30-40% and a disease control rate of around 80%. And in March 2019, the patient underwent further palliative surgery because of local symptoms, and apparently liver disease is under control. And further progression of abdominal lymph node and new lung metastasis with SBRT given. A lot of systemic therapy and a lot of local therapy to maximize treatment outcome. However, in September 2019, we have a PD of mediastinal and pelvic lymph node and new perineal nodule and bone metastasis. So we started regorafenib 80 mg daily and nivolumab 3 mg per kg every 2 weeks. Because at that time, we have the readout of the Regorafenib study showing very promising response. Patient tolerated very well with day 1 hand-foot skin reaction, and some skin rash. and the CEA dropped very, very nicely from 120 to 12.5. And PET-CT in November 2019, which is 2 months after the initiation of therapy, so very good response. This is the mediastinal lymph node that is very active and significantly enlarged, and just after 2 months of treatment, become nearly eumetabolic and decrease in size. So as the bone metastasis at the pelvic, as well as the perineal nodule that is palpable, it's also very light response. In January 2020, we increased to Regorafenib 120 milligrams per day because of the good tolerance, and try to do the dupilumab 480 milligrams every 4 weeks because it's near Chinese New Year time and the patient want to go back to mainland China and to reduce the frequency of Hong Kong hospital visit. However, in February 2020, CA further increased and we switched to dupilumab and DS1 and then denosumab. Unfortunately, the patient progressed quite rapidly afterwards with brain metastasis, and we give local treatment. He opted for palliative chemotherapy subsequently and finally succumbed in May 2020. So it's a very aggressive tumor, high load of disease, and he totally received 7 lines of treatment with multiple local therapy and with a very impressive overall survival of 15 months. He's really a fighter of the disease. So Regorafenib and PD-L1, I guess Wei Ping will talk about it in details later. Because of time, probably I can skip it. And so in a nutshell, we are trying to turn immune cold tumors to a immune active tumor by combining the blockade of the immune checkpoint inhibitor as well as the drugs like Regorafenib, which inhibits the VEGF signaling and the CSF1 signaling that is associated with tumor-associated macrophage and T-regulatory cell for immunosuppressive activity in the tumor microenvironment. And we also learned that in the subsequent mice experiment, the combination of these therapies showed promising results. So as the Regolifo study, showing a very impressive response rate of 36%, which is not expected of, which is certainly not expected of neither of the monotherapy with Regorafenib of Nivo and nivolumab. So it is a synergistic effect, and we are still waiting for a landmark study at the phase 3 level, which is about to open. So ladies and gentlemen, in summary, we know that Regorafenib is a standard of care in late-line treatment, but dose optimization, patient selection, and management of toxicity are essential. And we are certainly looking forward to the promising results